So, what are the clinical features of pancreatic adenocarcinoma? Clinical features like signs and symptoms. So, we have carcinoma of the head, and we have carcinoma of the body and tail. Then, we also have differential diagnosis of jaundice. So, cancer head, cancer body and tail, and things that looks like jaundice, right? We're not talking about pancreatic head, we're talking about things that look like jaundice. So let's get back to the clinical features of pancreatic adenocarcinoma. How does it feel? What does it look? So if someone has carcinoma of the head, if the cancer is in the head, then the tumor manifests relatively early by obstructive jaundice, which is usually deep olive green and pruritus. Commonly, there is no pain, painless, but sometimes it's painful. So pain usually signifies it increases infiltration or obstruction. The jaundice may temporarily lessen if an obstructing periampullary carcinoma sloughs. The liver is commonly enlarged because it is engorged with bile. This is also known as Courvoisier's law. So, the gallbladder is palpably distended in half the cases. Anorexia and loss of weight are also marked. So, as any cancer, of course, if you have cancer, then you will have loss of weight. This person will definitely lose weight. And anorexia. These are something which is there in every cancer. And so the tumor manifests early in the cancer of the head. This is an indication that it's in the head. Obstructive jaundice, which looks like deep olive green. This is the color. And you will not know because it has no pain. It's commonly painless. But sometimes some of the patients, they complain of like really painful, because really painful means infiltration is deep, or maybe there is like a significant obstruction, and the jaundice will become less. Okay, if the obstructing periampullary carcinoma sloughs. So this obstructing periampullary cancer, if this sloughs may be cut, I don't know, then the jaundice may decrease. This is something you have to remember, that something has to get sloughed off to decrease the jaundice. So the liver is commonly enlarged. Of course, we know that bloodstream spread primarily to the liver, so this liver becomes big, and also it is engorged with bile. Okay, it is like almost filled with bile. This is known as Courvoisier's law. Courvoisier's law, as you can see. And we have carcinoma of the body and the tail. That actually happens late, at first in the head, and then it spreads to the body and the tail, so it is late to show its presence. Pancreatic adenocarcinoma is late in the body and tail. The manifestations are non-specific. Like, you cannot specifically say something about this, so they are non-specific and include anorexia, loss of weight, and weakness. So it's like this person will definitely lose weight, become weak, unable to eat, the common things that happen in the cancer patients. So epigastric pain will radiate to the back as a late symptom. So if someone has pancreatic adenocarcinoma and this person has epigastric pain that actually radiates to the backside, it is very late symptom. But also it's like vague. It's not specific, right? I mean, how will you know that you have a cancer if just epigastric pain just radiates to the back? It's, I don't know, it's useless, I feel. And then we have migrating inflammation of the superficial veins. So this inflammation actually moves. Inflammation. Thrombophlebitis migrans. It is known to accompany visceral malignancies. Okay, visceral means organ and malignancies are cancers. So organ cancers. So if there is visceral malignancies, organ cancer, okay, then we have this inflammation which moves, inflammation of the superficial veins, thrombophlebitis migrans, and it is known to accompany visceral malignancies. As the condition is usually late on presentation, the liver may be enlarged from metastasis and ascites may be present. Of course, ascites, we heard that transperitoneal spread with peritoneal seeding and ascites. So thrombophlebitis migrans is also a new word here. We know that inflammation moves when there is visceral malignancies. So what are the differential diagnoses of jaundice? I mean, looks like jaundice, but it's not. We have hemolytic. Okay, hemolysis, breakdown of blood cells. So why will there be hemolysis? If there is immune, hereditary, okay, genetic, or maybe systemic infection. 3 causes: family, which is genetic, or immune, which is in the body, systemic infection, full systemic, like full body infection. So these things can cause hemolysis. Hepatocellular, maybe. It could be hepatocellular means liver cells, so viral, maybe bilharzia, cirrhosis, storage, or drug. So viral means because of virus, bilharziasis is bilharziasis, cirrhosis is the scarred liver, okay. And then storage or drug. Drug also causes actually hepatocellular jaundice. Drug is a problem in everything. Or maybe there is a storage issue. Cirrhosis, yeah. So, and third is obstructive, maybe calcular, malignant, stricture, parasites. Parasites can obstruct and then cause jaundice. I know it's like very, it's something that happens. If you imagine, yes, but in the books we don't see such stuffs, like parasites will obstruct it. And maybe narrowing also obstructs, like stricture or maybe malignancies. We know cancer, anything, or stones will obstruct. So regarding obstructive jaundice, calculi and malignancy constitute 95% of the causes. So like almost always it's cancer or maybe stone. Cancer obstructs. This is a new thing you have to keep in your mind. Cancer obstructs. And the difference is shown in table 5.3. It's the differentiation, okay, it's like differences between calcular and malignancies. So if you will find cancer in the elderly patients, which is a common, it's easy. It's always in elderly people, cancers. And stone in the middle age, okay. And stone is more found in the females, but cancer in male. And females will show, the calcular jaundice will be maybe long. It will stay for a long time at its stone. And this malignancy, the jaundice will be short For a short time you will see jaundice and then it disappears. So if it's for a short time, then you can actually think that it's cancerous. And then intermittent, like comes and goes in the stone, and in cancer the jaundice actually gets worse by time. And in cancer patients, the jaundice may be very deep, okay, but in stone it's like moderate. The abdominal pain in the stone is colicky. See, colicky actually, it's very related to stones. So stone causes colicky pain, and more in epigastrium and right hypochondrium, say epigastrium. So always the epigastrium pain when it comes to pancreas. And malignancy, abdominal pain is almost like absent. There is no abdominal pain, but if it is present, it is dull, like light aching, and it refers to back. So anorexia and weight loss are totally absent in stone. See, anorexia and weight loss are like biggest red flags in any cancer. So these things are not common in people who has no cancer, because only cancer people have things like that. And fever is maybe present in stones, but in cancer, no. Gallbladder is usually impalpable. Courvoisier's law, like the liver is so huge and engorged with bile that you cannot actually palpate or feel the gallbladder. But in cancer, you can feel the gallbladder. You can feel it, like you can feel it, right? You can. In the cancer, you can feel it. So, ultrasound shows that the stone calcular, it's like fibrosed gallbladder with stones. Ultrasound shows. And in the cancer, it shows markedly distended, thin-walled gallbladder. So this gallbladder has thin wall, and it is like distended, okay, like really enlarged. Why does it have thin wall? I have no idea. Cancer, but thin wall. So the CT scan will show gallstones in the calcular one. In the malignant one, it will show head neoplasm. It shows what it sees. So CT scan, perfect. It shows everything, right? And did you notice ultrasound actually shows the thickness of the walls? And ERCP is the endoscopy, right? So it shows the stone in CVD, of course. And in malignancy, it abrupt termination or failure of cannulation of CVD. ERCP shows abrupt termination or failure of cannulation of common bile duct. Like you cannot actually cannulate the common bile duct by ERCP if one has malignancy, so it's a big sign. Maybe you cannot go through it. That's all we have discussed, the clinical features and the differential diagnosis of jaundice, clinical features of pancreatic adenocarcinoma, which is divided into carcinoma of the head or carcinoma of the body and tail, and then DD of jaundice, and then the differences between calcular and malignant obstructive jaundice. Here we were talking about jaundice, right?